Dr. Lawrence Albiges. We have Dina Battle. I think we have Dr. Uzo is going to come up, and Dr. Kurtikoff. And what we're going to do is, these are our practice-changing papers of 2023, and we're going to just go, I think, in alphabetical order by the way the PowerPoints are, and then just have our discussants, our speakers, kind of go over the data, what they think, and then kind of I'll discuss with our panel their interpretation and how we're going to, is this going to change on Monday as one of our themes for this day, and how is it going to change our patients? So again, my name is Stephanie Berg. I'm a genitourinary medical oncologist at Dana-Farber. So we're going to start off with our first speaker. I'm pleased to announce Dr. Desai. She's an assistant professor at University of California, San Francisco. She'll start us off.
Thank you so much, Stephanie. I want to thank the organizers for the opportunity to present practice-changing papers of 2023 in medical oncology. I'll be presenting CONTACT-03, which is a recent paper that was published in The Lancet by Dr. Pal and colleagues. It is a multi-center randomized open-label phase 3 trial, which included patients with advanced metastatic clear cell or non-clear cell RCC with or without sarcomatoid component. Patients had to have progressed on a prior immune checkpoint inhibitor. Patients received patients were randomized in a 1:1 fashion to receive either atezolizumab along with cabozantinib. The dose was 60 milligrams daily versus cabozantinib single agent 60 milligrams daily. Patients were stratified based on the IMDC risk group, histology, and the most recent line of immune checkpoint inhibitor. The co-primary endpoints here were progression-free survival and overall survival. Key secondary endpoints included investigator-assessed PFS, overall response rate, safety, and duration of response. As you can see in the Kaplan-Meier estimate for overall survival in the intention to treat patient population, there was a significant overlapping of the curves. There was no improvement in overall survival in the combination arm compared to cabozantinib single agent. The p-value here was 0.69 with a hazard ratio of 0.94. Similarly, there was no improvement in progression-free survival in the ITT patient population with a median PFS of 10.6 months in the combination group compared to 10.8 months in the cabozantinib single agent group. Similarly, the overall response rates were very similar in both the patient populations, in both the arms, atezo and cabozantinib versus single-agent cabozantinib. Importantly, there were no complete responses that were observed in the combination arm of atezolizumab and cabozantinib. There were 50.5% responses that were seen at data cutoff in the combination arm versus 52.9% responses that were seen at data cutoff in the cabozantinib single-agent arm. The median duration of response was also numerically inferior in the combination arm versus cabozantinib single-agent arm. Also importantly, the combination arm had a lot more serious adverse events compared to the cabozantinib single-agent arm. There were 24% serious treatment-related AEs in the combination arm versus 11.7% AEs in the cabozantinib single-agent arm. So moving forward, so we know that the CONTACT-03 study was negative, right? So we also have another ongoing trial, the T-NIVO2 study, which will evaluate tivozanib along with nivolumab versus tivozanib single agent in a very similar patient population. The only important difference between these two trials is T-NIVO2 is going to be evaluating nivolumab, which is a PD-1 inhibitor, compared to atezolizumab, which is a PD-L1 inhibitor. So take-home messages. CONTACT-03 was the first randomized phase 3 trial to examine the efficacy and safety of PD-L1 inhibitor following progression on or after prior treatment with immunotherapy. The addition of atezolizumab to cabozantinib did not result in improved clinical outcomes. So the use of immune checkpoint rechallenge should be deferred until there is level 1 evidence to support this practice. Thank you.
Thank you, Dr. Desai. I'm going to go down the line and start with Dr. Kurtikoff. And we know, Tony presented this, and ASCO. So it was big news. We all knew this was coming. So especially from you and Dr. Uzo from the urologic perspective, what do you guys think? Is this practice changing?
So I think the big question remains, I mean, this is atezo, and its activity is, is sort of, this IO is, as we know, not as active in the kidney space as others. And I think the conclusions of the sort of the takeaway, the narrative of this trial is that, sequencing IO it should be, it should not be encouraged. I mean, my big question here is, if somebody was, hadn't seen nivolumab or Pembro, does this really show us that they won't benefit from it? So, to me, I don't think it does.
Dr. Uzo?
First, thank you for picking a negative trial. I always think it's great to not only show positive trials what you should do, but negative trials what you shouldn't do. Second, congratulations to Monty Paul, my friend, who somehow seems to get negative trials into Lancet with a very high frequency, Motion 010.
Absolutely.
So kudos to him. Third, you guys all talk about Cabo being toxic. I'll choose personal experience. My dad was on Cabo about 10 years ago, and the dose reduction was 60, and it was intolerable. It's a really hard drug from what I could see. I think the last comment that you make, should you use IO in second line? I'm not sure that excluding IO in second line, and I'm no medical oncologist, but I'm not sure that using atezo data to make that statement is really the most appropriate, given Bernard's comments earlier today.
Dina from Casey Cure, thank you for joining our panel.
Thanks for having me. Obviously, I'm not a medical doctor, so I'm not going to approach this from a medical standpoint, but from a patient perspective. And the question is this practice changing? And, sadly, it shouldn't be practice changing, because I'm not sure we should have been giving IO in the second line in combination in the first place. But I think it is happening routinely, and so I think it needs to be practice changing. And I think the final conclusion is what you said, I think, is perfect, which is we need level 1 evidence before this just becomes routine standard of care. Patients, when they have cancer, if you tell them, I have 3 drugs, I have 4 drugs, they'll say, can I get 5, right? And we really need to make it clear that more is not always better. And until we have the evidence for that, it shouldn't be done.
Thank you. And Dr. Albajes?
Thank you. Well, first I want to thank the planning committee for the invitation to be part of this panel and for the great program. So I think I'm conflicted, obviously. I took part in this study. It's a pragmatic question. I think it was important to address that with the caveat that atezo is not maybe the PD-1 or PD-L1 inhibitor we wanted, or with a higher likelihood to be active. So we'll know more from TiNivo2, but it's a very important question. I will also think that this trial will be the benchmark for further study. This is what we expect of a second, third line regimen. And so ultimately, it's important to learn from negative trials. So that's my take. I would rather have a positive trial.
Thank you so much. Okay, next up, Dr. Shapiro.
Can I ask a quick question
yes.
to the panel? So right now in our guidelines, like NCCN, we don't have any level 1 evidence in the IO refractory setting. This, I think, is our first phase 3 study in the IO refractory setting, and 800 patients or so. I mean, does this establish Cabo as level 1 evidence post-IO now for our guidelines? Should we, I think, Lorenz, you said this becomes a new benchmark. So does that mean that's level 1 evidence for Cabo?
I think this is important. This trial, as we said, is in the post-IO and mostly post-TKI as well settings. So the short answer is yes. However, we do have another trial because you couldn't pick belzutifan LIGHTSPARK 005 given it was not published yet, but it has been presented. So we also have another randomized study in the post-IO, post-TKI setting to enrich your guidelines.
But the LIGHTSPARK is only PFS, correct?
So LIGHTSPARK is only PFS, but the thing is it's not a second-line trial. It's a third and fourth line trial. 85% of patients were treated in third and fourth line. So I also want to stress that in this late stage setting, PFS does matter. And I would love to hear from Dana, her point of view about that.
Well, I think that's going to be complicated. I think LightSpark is exciting. I think the idea of belzutifan is exciting for patients, for them to have a new mechanism of action. But the one thing that concerns me a lot is over and over again when people are asked who is the right candidate to get belzutifan, I hear a lot of different answers, and I don't think that we have a real clear answer. We have a very crowded line of drug therapies, and I think to unleash it without really knowing who is the right patient to get it at the right time and not having a lot of experience with the drug and the side effects, I think we need some more real-world experience before we can set that as the standard.
So that's a plea for biomarker development, and I fully support that. And I think that's the only piece that was missing in the great belzutifan session we had, is how can we move forward with the biomarker piece with this agent. But that being said, it's a new mechanism of action drug that is extremely well tolerated, that has demonstrated activity against active comparator, including in heavily pretreated patient population. So to me, that's a game changer for our patient. What we do need now is to have the assessment of this drug earlier in the disease course.
Thank you, everyone. All right, up next, Dr. Shapiro.
Thank you for the opportunity to present. I'm going to give you my quick elevator pitch of what I think was a truly excellent paper this year. So just to set the stage for why I chose this paper, I think you need to understand the challenges that we face as surgeon scientists. So from a clinical perspective, selecting patients for surgery really comes down to who, when, and how. So who, of the patients that I operate on, what I really struggle with is who has indolent disease and who is going to progress after surgery if we're doing surgery in the localized setting, and which of those patients has higher enough risk disease that they should warrant adjuvant therapy. Now in the metastatic space, when becomes a particularly difficult question. When should we offer surgery up front versus when should we offer surgery after systemic therapy has been delivered? And then as a surgeon, how do I deliver surgery? How can I limit the morbidity of my surgery so that I can get patients back to their life more quickly? Now, on the scientific side of things, particularly my research is interested in how RCC develops an immune response and how it evades that immune response. Also, that brings in challenges of tumor heterogeneity, and the ultimate problem is we don't have great models for representing the tumor microenvironment. So I think this paper truly does an elegant job of answering some of these questions from more of the scientific aspect of things. This is a paper from the MD Anderson group led by Dr. Gianni Genovese and Luigi Pirelli, as well as investigators across the globe. In this study, I'm going to try and quickly summarize, but essentially one of the major breakthroughs that they developed was a genetically engineered mouse model that they're able to actually recapitulate some of the RCC microenvironment, actually generate metastatic disease that has a similar distribution as what we see in humans. They also investigate how RCC develops an immune evasion response. So basically the RCC cells are able to suppress the interferon response and avoid the immune system. And lastly, they address issues of tumor heterogeneity. They show convergent tumor evolution in RCC cells across species, so both in their murine model and in humans. So you can see from this paper, they address many of the challenges in terms of how the tumor responds to the immune system, issues of tumor heterogeneity, and then what I think is really important is a really exciting new model that can help us recapitulate the RCC environment. So I know you may be disappointed that I didn't show any retrospective series of surgical outcomes or large partial nephrectomies that don't change anyone's GFR, but I truly want to point out, I think the discoveries made in papers like this have significant translational potential, and I do think that with further investigation and further work will ultimately help me select patients for surgery, inform my surveillance strategies, and even inform who should get adjuvant therapy. So thank you.
Thank you. All right, Doctor, we're going to start from this way. Dr. Albertus, what do you think? Is it practice changing?
Okay, so I think as a medical oncologist, understanding the tumor biology is key. And to your point, I think what is important is how much that will help us to either have an escalate or a de-escalate strategy. And that's the bottom line, either in the adjuvant space or in the metastatic space. In which patient do we need to intensify, go for adjuvant, go for triplets, or in which patient can we actually say, oh, this patient didn't carry any poor risk features, and we don't require systemic adjuvant therapy, for instance. So this paper is important because it is a very nice model. However, what I would love is conclusion from this manuscript to be taken into prospective trial, and that part we can't say we're there yet. But I mean, it's a step forward. So in this regard, it is very relevant, but it's not impacting. And it's not impacting because we haven't yet the demonstration that this preclinical model can actually apply in a, let's say, a localized large cohort of RCC, where we could define upon adjuvant strategy, for instance.
Thank you. Go ahead, Dina.
Well, I majored in political science, which really doesn't have anything to do with science at all. And when I read this paper, I would just like to say thank you for including pictures. I'm not going to speak to the science of it, but I will say from your slides, the questions that you're asking are the questions that matter significantly to patients. And this is something that we've seen in our evidence over and over again. Patients want certainty. When they go in for surgery, they want to know afterwards, is my disease going to come back? What are my chances? What type of therapy should I get? Patients in the metastatic setting want to know, is there a cure for me? Am I going to respond to this? So I think research that gets us closer to that point is where we need to be going. So whether this research gets us there or not, I'm not sure, but thank you for asking those questions.
Any paper that helps me think about the biology of this tumor helps me treat the patient affected by the biology of this tumor. And I can say that, you know, without doubt, Samra's work for TraceRx did that, and so does this paper. So it doesn't really answer sort of the truncal mutations, the whole idea of chromotripsis and loss of 3p, but it does talk about sort of the progression and the clonal evolution and the chromosomal instability and the loss of 9p and 14q and how that might you know, sort of cause a force metastatic potential. And I think the interesting thought here that I had is we spend so much time talking about the results of chromosomal instability and DNA mismatch repair. You know, this might actually open you up to an understanding of how to maybe prevent that chromosomal instability. So I thought this was really taught me biologically and therefore helps me to rethink the way I think about the care of the patient.
Well, it's much easier to comment on papers where you do left nephrectomy with the right hand and right nephrectomy with the left hand, and this is clearly not my space, but I mean the mirror. You know, back in sort of fellowship days, I worked with murine models, and it's such a journey from, you know, from benchside to bedside that you know, some of the little I understand about models in itself is, you know, how generalizable is this? How quickly can you bring this? How, you know, some of these models where you have to, you know, sort of implant the human immune system into a mouse in order to really understand what the xenograft to immune system interaction is. I mean, the costs, my understanding, are so prohibitive that it's, you know, very few labs around the world are actually going to sort of pick up that work. So, I mean, with these kind of papers, you know, for me, it's sort of understanding the logistics. You know, how easy is it to take this paper and bring it into your own lab without sort of major funding and sort of replicate some of this and build upon it?
Any last words, Dr. Shapiro?
No, I think it was a great paper.
Thank you. All right, last one. Dr. Trunk's coming up. Last but not least.
Hi, good afternoon. Thank you, Dr. Burke and the Planning Committee for the opportunity to present. So this afternoon, I'm tasked with presenting a practice-changing paper in radiation oncology. So it comes at no surprise that I picked this paper, which has been referenced several times during our meeting. The title is 5-year outcome after stereostatic ablative body radiotherapy for primary renal cell carcinoma, an individual patient data meta-analysis from IROC. While the standard treatment for early stage kidney cancer is surgical resections, there is a substantial number of patients who may not be able to tolerate surgery due to either advanced age or other competing comorbidities. Therefore, stereostatic ablative body radiotherapy, or SABR, have been investigated as a potential non-invasive ablative therapy for these patients with medically inoperable disease. The primary objective of this study is to assess the long-term outcome of SABR in localized primary RCC. This is an individual patient data meta-analysis of 190 patients from 12 institutions worldwide from 2007 to 2018, so 11 years period. The inclusion criteria for the meta-analysis is that the patient age over 18, at least 2 years of follow-up, no prior local treatment for RCC, and localized disease. The primary endpoint is investigator-assessed local failure rate using radiographic evaluation based on RECIST criteria. The secondary endpoint is adverse event pattern of failure, renal, and survival outcome. This is the major result from the study. The median age at diagnosis was 74. Median tumor size is 4 centimeters, ranging from 2.8 to 4.9 centimeters. 75% was deemed medically inoperable by referring urologists. 29% have solitary kidney. For patients with 2 kidneys in the study, most have even split renal function. The median renal nephrometry score was 7. Median follow-up was 5 years. 43% was treated with a single fraction SABR with 25 gray, and 57% have a median of 4 fractions and a total of 42 gray delivered to the kidney. The primary outcome showed 5-year local failure rate of 5.5%, and 7-year failure rate was 8.4%. 2% have local failure in the kidney, 7% develop metastatic disease, and another 4% have both local failure and distant metastasis. 77 deaths during the study was attributed to non-kidney cancer causes. 4% of patients require dialysis after SABR, and most of these are patients with chronic kidney disease to begin with. Most treatment-related toxicity are grade 1 and 2, the most common being fatigue. Only 1 patient developed grade 4 toxicity, which is duodenal ulcer at 1.4 months and gastritis at 16 months. Kaplan-Meier plot stratified by single versus multi-fraction treatment show that single treatment is associated with lower local failure and distant metastasis. So the take-home message from this study for me is SABR is a potential treatment option in the setting of localized renal tumor for patients, in my mind, with tumor greater than 4 centimeters who are unfit or unwilling to undergo surgery. The remaining question is, as we can see, single fraction SABR shows significantly better local control than multi-fraction SABR. However, the mechanism of this response to radiotherapy is unknown, and the optimal dose of fractionation in SABR in RCC have yet to be determined. Thank you.
Okay, this is more up my alley. So there's a lot here. I mean, first of all, I'd like to congratulate Dr. Silva. I mean, this is tremendous work. I mean, this is disruptive. This was, the narrative was very strong. The radiation doesn't work. They did it in the right way. Really, experienced across the world. We now know that SBRT to the mass can, have biological effects. Now, stepping back and this really just is sort of just enters the existing debate between ablation and surgery and surveillance, right? I mean, in the localized kidney cancer world, we, you know, some of us a little bit cynically and would just say that, you know, ablation and now SBRT is really just surveillance with a really good billing code, right? So, I mean, the bar is high. You know, if you leave a lot of these tumors alone, and you know, we've written from Fox Chase sort of some of the seminal work on this, where even with large masses, you can leave people for years and not much happens. And the few folks who do metastasize, it is difficult to prove that whether you gave SBRT or ablation to that mass, you would have changed the arc or you know, the destiny of that disease. So I think this is another tool. Some patients are, you know, they can't get a haircut, much less even sedation for ablation. So this is another tool in our belt. And you know, radiation works. We just went on a case series of radiation to vena cava thrombi, and incredible. I mean, one of my patients was on there. It's, I mean, just a, you know, somebody who is again very comorbid, cannot get any surgery. You can control growth of a renal vein thrombus with radiation. So this is definitely game changing. I'm just not sure. You know, I think this is on the, you know, sort of edge cases here that where you would use it.
There's always a risk in all that we do of overtreatment and undertreatment, and obviously matching the biology to the therapy is always difficult. So I've said often that, you know, it's easy to overestimate the therapeutic benefit of some of our interventions, and I've been called a therapeutic nihilist. On the other end, I've said that, you know, we should watch more of these, and I've been called a active surveillance acolyte. In the end, you know, it's very difficult to know what the biological consequences of radiation therapy to the small renal mass are. It's just similarly as if it's difficult to know what the RFA, the true RFA implications are. When I was training, it was we never gave radiation to the kidney because the kidney couldn't tolerate it. So what I've learned here is actually the kidney can tolerate it. What I didn't like here so much is that, you know, local failures were investigator defined, and they were less than metastatic failures, which I found a little bit unusual, because in most active surveillance data, in most ablation data, that's never the case. You fail locally more often than you fail distant, and this was the reverse. So I think it's important. I think that it's another tool in our tool belt. You got to pull it out, you know, occasionally, but I think we've got to be very careful of overestimating what it really means.
I think diagnostic uncertainty is such a huge problem for this patient population, and the psychology of being told, oh, don't worry, it's probably not a problem, is really hard to live with. And I think having a treatment that is less invasive for these patients until we have better diagnostic certainty is something that is very much needed. You're right, it could be overtreatment, and it could also be undertreatment, but I think it's certainly better than a nephrectomy, which is what is happening in a lot of cases. So I think being able to use this in the community setting, in the real world setting, for a lot of patients, I think we could potentially save a lot of kidneys, and I think there's certainly value in that.
So I think this is practice informing. What we can learn from this trial, from this study, is feasibility. So it is feasible, it is safe, and we now have numbers saying that the GFR loss may be in the range of 10 to 14 milliliters per minute. So it is quantified, the impact on the kidney function. However, it doesn't set the frame on who should receive that, and that was the very first comment. Most importantly, what we do know is that those patients are unlikely to pass away due to their disease. And so once again, it reinforced the message on maybe those patients would have been fine with observation only, but at least we know it's feasible and it's safe.
Thank you all so much. We're a little bit behind time, but if there's any questions, but I was just going to say it's, you know, it's something that throughout this whole meeting about a multidisciplinary discussion, not only, of course, with our patients, but with other folks in our departments, our divisions, going through, especially with all this data coming out so much. It's utterly important to, again, I think Dr. Kudikoff noted the bench to bedside and bedside back to bench, and how we're going to advance kidney cancer, how we're going to cure kidney cancer, right? And how we're going to save our patients, talk to our patients, work with them, trial discussion. So this has been wonderful. And again, thank you all to the panel for discussing this. I know some of it, if we didn't, it kind of just put two of you guys on the spot, but it was great. And thank you again to the committee and to, of course, to our two chairs who are going to be coming up and closing up the session. Thank you so much.